And I want to welcome Professor Jonathan Hourihane, Professor of Paediatrics and Child Health at University College Cork, to this meeting. Hourihane.
Thank you. Excuse me. Thank you, Deputy. I'm Jonathan Hourihane. I'm Professor of Paediatrics and Child Health in UCC. I was a member in 2012-2014 of the Food Allergy and Anaphylaxis Task Force of the European Academy of Allergy and Clinical Immunology, whose documents were published and launched at IACI's annual Congress in Copenhagen last week, and I submitted this as part of my written evidence in PDF form. There are other scientific documents also included. I'm co-chair of IACI's Food Allergy and Anaphylaxis meeting, the world's biggest food allergy meeting, which is scheduled for Dublin Convention Centre in October, and the committee are all invited to attend that as they wish. I'm principal investigator on Ireland's first prospective study of anaphylaxis with Professor Ronan O'Sullivan and Dr. Joanna Maris, funded by the National Children's Research Centre in Dublin. I co-lead with Dr. Byrne the Anaphylaxis Initiative in UCC, and I'm chairman of the Irish Food Allergy Network. Until last week, I was secretary of the Irish Association of Allergy and Immunology, which receives unrestricted financial aid from industry, including contributions from manufacturers of auto-injectors. So I declare that as a relative conflict of interest, although it is an unrestricted grant. I'm a board member of the Clemens von Pirquet Foundation, an independent charity affiliated to the Professional Association of IACI, which promotes the scientific study of allergy in children. And I've received research funding and travel grants from other sources. I've also visited Boston recently to investigate the possibility of bringing oral immunotherapy practices to Ireland. My submission is as follows. Anaphylaxis is a term coined by the same Clemens von Pirquet in the earliest 20th century to indicate the phenomenon of lack of protection. Prophylaxis is protection, and anaphylaxis is lack of protection. So anaphylaxis can loosely be considered the opposite of that, of prophylaxis. The use of the term anaphylaxis is now broadly related to allergic reactions to allergens, which can be foods, what we're talking about mainly today, pollens, we're in the middle of hay fever season at the moment, house dust mites, which cause asthmatic attacks, and medicines, which are far the most common cause of anaphylaxis because they're administered to people by routes that are not natural, if you like, with injections and other forms. So anaphylaxis is a common problem within hospitals, but we are probably more focused here today on outside of hospital community reactions. Recent European position statements and systematic reviews recognize how difficult it is to collect data because this disease is diffuse in its presentation and it's difficult for unfamiliar physicians to recognize it, and for nurses and other health professionals and members of the public and parents and other carers. Maybe it's to be noted that 20% of acute asthma deaths are probably anaphylactic in nature because the final common pathway in anaphylaxis can be wheezing, and the person may be too unwell to tell you why the wheezing started. Anaphylaxis is also, deputies and senators, likely to become more common because we're moving into a dynamic phase of management of food allergies where we're giving the foods that people have been rigorously told to avoid. And we know that in the oral immunotherapy programs, it's harder to have the treatment than the condition where you simply avoid the food rather than eating it. Allergic reactions are becoming more common. So that's going to, iatrogenic anaphylaxis is going to become more common. Immunotherapy will be moving from research protocols to the more routine care in other parts of the world. But as usual, Europe and particularly Ireland is going to be behind that game due to inherent caution and uncertainties, I think. People who are at risk of anaphylaxis, the lack of protection, fundamentally have a lack of protection from this disease because people are unaware of it, the legislation is not in place to protect people who may be aware of it, and the families are uncertain who can help them with it. It's my view that this could be addressed with simple or even complicated legislative measures that will be both innovative and will be widely welcomed by the public. Death is rare from anaphylaxis, but the prospect is not. The prospect is real and is a grim part of daily life for families. They feel they're being followed around by the Grim Reaper, and that's a phrase that I would hear every week. More classical term would be the sword of Damocles over their heads. They feel that the Reaper is going to take their child if they make the tiniest mistake with their food. And that's a hard way to live. This inhibits families sharing their child's life with other carers and adults who may be in loco parentis, and it limits their child's normal integration into social groups, after-school clubs, sports, social parties. These are all normal parts of life which are manageable allergy-exposing situations, and they are manageable if proportionate restrictions and precautions are in place. The act of handing over adrenaline auto-injectors from an experienced but highly anxious family to an inexperienced and unfamiliar family can be very stressful and can limit these interactions for families. The United States Executive has enacted the School Access to Emergency Epinephrine Act. However, it must be acknowledged that President Obama had a personal interest in this because his daughter is peanut allergic, and she has eaten food in Ireland, in Dalkey. So there must have been precautions put in place for her in a way that we don't think is worth putting in place for other children. The intention of this act is to indemnify and encourage schools to have generic adrenaline available to administer to people who do not have their own adrenaline kits available, or more likely to people who are not already aware that they are allergic to a food, such as Yvonne found out in adulthood. There is no reason why this administrative effort by the world's largest administration could not be replicated in Ireland, which has far lower levels or effectively no on-site medical support facilities in schools. In the UK, there are school nurses. In America, there are school nurses and matrons. In Ireland, that is not common in the public school system. However, this must come with appropriate training packages and renewal mandates and competency measurements and training and renewal, because it's not just something you can stick on the wall with masking tape. It's got to be taken down, practiced with, and we've got to be familiar with it in a way that allows us to be confident in our use of it in a situation where everything else has gone wrong. It's a crisis that can be avoided. It is not simply sufficient to put these kits into restaurants and catering outlets without the backup of training and support that is measurable and trackable back to the health service who would be responsible for it ultimately. We have far fewer allergists than America or European countries. Finland has approximately the same population as us and has 100 paediatric allergists. Access to allergy services in Ireland is very difficult indeed. The Cork University Hospital Paediatric Allergy Clinic is the largest in the country, and I personally receive twice as many referrals each week as all the other services in the hospital, which would be 2 consultants who are neurologists, 2 who are respiratory, 2 who are diabetes and endocrinology. I'm a 0.5 position because I'm an academic, and I receive twice as many. So pro rata, that's 4 times as many referrals. My services wait times are all in breach of HSE guidelines, and I have no idea how to fix that. Waiting times for the allergy clinic in Cork are at least 1 year for routine appointments and 3 years for a diagnostic food challenge. The need, therefore, to empower patients and empower other partners in the social contracts that we make with families may be even more critical and achievable in Ireland, where access to the health service may be more difficult. If a person who carries prescribed adrenaline needs assistance in using their adrenaline, this assistance is covered by Samaritan-based legislation and precedent. The administration of unprescribed medication by health professionals is also covered by existing legislation, as previously outlined by one of the panel. The gap in Irish legislation relates to the administration by non-medical staff of adrenaline to people for whom that adrenaline is not specifically prescribed. The United States was able to solve this, and there's no reason why the Oireachtas could not do the same, in my view. In 2009 and 10, UCC's proposed pilot study engaged in extensive training and recruitment of what we call first responders for a unique program of university campus-wide allergy stations beside existing defibrillators. And in my submission, if you have a copy, there's a picture of a locked box beside a defibrillator. The black box here is locked. It's not that somebody can walk up to these and put a €2 coin in and get them out, or that they are openly accessible. They would have to call a first responder to come and assist them. So it's not something that could be easily extracted without a trained person helping. We suspended this program voluntarily in February 2011 at the time of confusion over the morning after pill administration or dispensation by pharmacists. It became apparent to us at the time that the legislation under which we were presuming protection would be available to us as the prescribers or the responsible physicians was now unclear, and we personally decided we could not take that responsibility. From 2011, when we voluntarily suspended our program, we have sought advice and guidance from regulatory authorities. We received no assistance sequentially from the Irish Medicines Board or the Chief Pharmacist's Office up to January 2013, when a TV-facilitated meeting with the Secretary-General occurred. It's my unfortunate comment that no material progress has occurred since then either, despite multiple inquiries. Since Emma Sloan died of anaphylaxis in Dublin in December 2013, our study in Cork has received details of 36 more cases of survived anaphylaxis in Irish children. Reporting varies regionally, obviously reflecting variable medical awareness of the condition. It's my view that more cases are inevitable, and another avoidable death is unfortunately inevitable, even if that sounds like a contradiction in terms. I think these are treatable and avoidable deaths. Continuing legislative inaction could expose the state, its ill-equipped schools, and its healthcare providers to liability in such an event. And I think you've also heard that from Yvonne. If Emma Sloan had been born Emma Obama, we would not be sitting here today, but she might be alive and well in the United States. The wider governed availability of adrenaline in the community and easier access to more clinicians who understand anaphylaxis are achievable, affordable, and uncontroversial public healthcare innovations that meet several of this government's aims to improve patient autonomy and self-care. Thank you.